Okay. Okay. So we stopped last week here on leukocytes. Okay, so we said leukocytes are found on which level? Are they on the hematocrit, the lowest most, or are they at the topmost layer, the plasma, or are they in the middle, the buffy coat? Yeah, they are in the middle, the buffy coat. So leukocytes, they are white blood cells, and the blood cells that protect us against infection and against other diseases. So these leukocytes, they are the least abundant because they are made on demand. We don't get sick all the time. We don't get infection all the time. We get infection from time to time. So they are made based on need. So we said that if you come to school, you're going to find the regular number of police officers. If you come one day and you see there's thousands of police officers, so you know there's something wrong. So same thing. If we do blood work and we see there is a vast increase in white blood cells, that shows you there's either a huge infection or maybe there's cancer, because cancer is uncontrollable cell division, or uncontrollable cell division, and white blood cells are cells, white blood cells. So you can have cancer of the bone marrow that gives too much white blood cells. They have a conspicuous, meaning a very visible, identifiable nucleus. They retain their organelles because they need to make proteins, because they attack with these protein enzymes, these granzymes, the proteolytic enzymes, the degradative enzymes, the metalloproteinases, all of those enzymes, they use them in the granules. Remember the granules that they used in order to attack these microbes? And the granules are found in the cytoplasm. So all the white blood cells have lysosomes. These are known as non-specific granules. So they target indiscriminately. They target all the microbes. Doesn't matter if they are a parasite or a fungi or a bacteria or a virus. Then these granulocytes, these are a group of white blood cells that have specific granules that contain enzymes and other chemicals employed for against particular pathogens. So when you look at the structure of the leukocyte, you see that they gotta have a nucleus because they have activity of transcription. They need to make proteins. There are ribosomes and these pseudopods. What are these pseudopods? These pseudopods are appendages that enable the cell to crawl and walk. So this white blood cell obviously need to walk to the tissue. They need to be able to arrive to the tissue that is undergoing infection so they can fight these microbial organisms, these pathogens. So they must have these pseudopods. You see these pseudopods. The lysozymes, that's where you have your lysosomal enzymes that degrade, and they are used as weapons. They have acid also. The mitochondria is to provide the white blood cell with of ATP and the energy. And the ribosome is where we translate this DNA transcript that we made here inside the nucleus. Okay, the leukocytes, we said, are divided into two types. We have the granulocytes and the agranulocytes. Granulocytes contain specific granules, and they include three types of white blood cells. So granulocytes meaning that they have granules on them. So the neutrophils are 60 to 70% of the circulating new leukocytes. These neutrophils, they are the most abundant. So one of the most important questions, one of the most important facts we need to know is that which of the granulocytes is the most abundant, and that is the neutrophils. Very good. They are also called the polymorphonuclear leukocytes because of their varied nuclear shapes. Polymorphonuclear leukocytes. So their nucleus is not the same from one neutrophil to the other. So they are barely visible they have barely visible granules in the cytoplasm. They have 3 to 5 lobe nucleus. Now the eosinophils, they stain red. They are about 2% to 4% of the circulating leukocytes. So their numbers can increase, that is known as eosinophilia, during parasitic infection. So if you do blood work for a patient and you see that the number for the eosinophils is so high, then most likely than not that this patient obviously has an infection, but is not a bacterial infection. If it was a bacterial infection, the patient would have neutropenia. They would have a lot of neutrophils. But here they have a lot of eosinophils. That's an example of a parasitic infection. They phagocytize antigen-antibody complexes and allergens, and they release enzymes that weaken or destroy parasites, such as the worms. So these are the ones that deal a lot with the parasites. So a high-yield concept is that what are eosinophils mostly useful to attack who? They are there to attack the parasite, worms. So a patient who has some worm infection or parasitic infection like malaria, then you bet 100%, are they going to have a lot of neutrophils, a lot of eosinophils, or a lot of basophils? Very good, eosinophils. Okay, basophils. So less than 0.5% of the circulating leukocytes are the basophils. These are the least abundant. So if you're asked who's the most abundant, 60 to 70%, that's your neutrophils. If you see these eosinophils, which ones are the second tier, about 2 to 4%, these are the eosinophils. But basophils, these are the least. And they have an S or U-shaped nucleus. And what is so special about them is that they secrete histamine and heparin. And you need to know that. So who are the white blood cells? The only ones who secrete histamine and heparin, the basophil. What does histamine do? Histamine is a pro-inflammatory agent. So that's why we use antihistamines when we have inflammation. If you have redness, heat, itchiness, pain, swelling, for allergies, excellent. So we use antihistamine because the histamine is all about inflaming things. Inflammation is a pro-inflammatory agent. And if you want to do inflammation, during inflammation, we studied inflammation last semester. What is inflammation? You know, in inflammation, do you expect a lot? Do you expect a lot of blood supply during the phase of inflammation to the tissue that is undergoing inflammation? Do you expect a lot of blood supply or a little? A lot, because there is over there microbial infection. We need as many white blood cells as we can. We need as much nutrition as we can. We need as much blood supply to pass by so we can remove all the metabolic waste. So that's very important to have vasodilation. So vasoconstriction is not helpful in inflammation. It is helpful to have vasodilation. And that's how we have shock. So a patient who has systemic shock because they have something known as septic shock. Raise your hand if you heard of something known as septic shock. So septic shock happens when there's an infection and it's going on and on and on. And you know, with the infection, what happens to the blood vessels? Do they widen up or do they get tighter? They widen up. So when they widen up, what happens to the blood pressure? Does blood pressure go up when you increase the diameter, or does it go up when you decrease the diameter? So think about it this way. If the water is coming out through a water hose, if you tighten up the diameter of the water hose, does the water come out harder or easier? If you put your thumb inside the water hose and you tighten it up, you constrict the water hose, so it's not like that anymore. Now it's like this. Is the water coming out the water hose harder or less? It's harder. So vasoconstriction causes high blood pressure. Now, in inflammation, we vasodilate to make more blood to arrive. Just because in vasoconstriction the blood is coming out harder doesn't mean more. It just means it's coming out harder. But in vasodilation, it comes out more. So now in vasodilation, a lot of blood is flowing, and what happens to the pressure? Drops. So that's an example of hypotension. You didn't lose blood yet. You're losing blood pressure. So now the patient, they undergo vasodilation, hypotension, until they die. So that's how septic shock happened, because of histamine and cytokines causing too much vasodilation that causes generalized drop in the blood pressure. They also secrete heparin. Heparin is an anticoagulant. It makes your blood thicker, or does it make your blood softer? Thinner. Makes your blood thinner. So my relative died back home. She was pregnant, and you know, pregnant mothers, they have high coagulation. Their blood gets really thick, so they need to take the enoxaparin. They need to take a shot that will make their blood thin. Otherwise, they suffer from deep vein thrombosis. So a blood clot is going to travel from the bottom of the foot to occlude the passageway of the pulmonary artery. So that's exactly what happened to her, because she didn't take the shot and she died. So that shows you heparin is very important to make your blood loose. I had another relative, he died because he was given too much heparin now. When he had too much heparin, they realized that if they just, his daughter was trying to wipe food from his mouth with a napkin, and then some cut happened, and then he bleeded so badly. So the blood was so thin. So we need balance. We don't need hypocoagulation. We don't need hypercoagulation. We need eucoagulation. So we need the right balance. So heparin is secreted by the basophils, and they promote the mobility of other white blood cells in the area. So now look at granulocytes. Granulocytes, these have granules inside them, like the neutrophil, the eosinophil, and the basophil. They have granules. Now the agranulocytes, they lack specific granules, and that includes two types of lymphocytes. They have B lymphocytes and T lymphocytes. Very good. So the lymphocytes, they're about 25 to 33% of the circulating leukocytes. When do we usually notice that there is basophils? That increases with viral infection. So bacteria, you have neutrophils. Parasites, eosinophils. Basophils, when you have some viral infection. Sinusitis, or rhinitis, when this mucosal layer in your nares and in the vestibules are inflamed because of some RSV virus in the air, or the rhinovirus, or the chicken pox, then your basophils are going to be increased. So why do the basophils secrete anticoagulant heparin? So they can make the blood so thin, so other white blood cells can maneuver quickly and get there where they are called for action, for combat against the infective microbes. So the numbers increase in diverse infections and immune responses. They destroy cancer, foreign and virally infected cells. So you see the lymphocytes destroy virally infected cells and cancer cells and foreigner cells. They present antigens to activate the immune responses. And they coordinate actions of other immune cells, and they secrete antibodies and provide immune memory. So now let's look at the agranulocytes. You have the monocytes. The monocytes are about 3 to 8% of the circulating leukocytes. You know that monocytes, they are in a primordial form. They're not ready, so they don't fight in the form of a monocyte. They circulate as monocyte, but when they detect an infective microbe to destroy, they convert. They go from monocyte into macrophage. So you don't have macrophages. Macrophages only change. You remember the Pokemon? So the Pokemon, you become something else. So these monocytes, they are circulating. Once they see something, they become macrophages. So that's very important. So usually they are the largest white blood cells, and they are ovoid, circular, and they are in the kidney. They have a kidney or a horseshoe-shaped nucleus, and the numbers increase in viral infections and during inflammations. They leave the bloodstream and they transform into macrophages. They leave the bloodstream and they transform into macrophages. They phagocytize pathogens and debris. They phagocytize pathogens and debris, and they act as antigen presenting cells. So they present cells, meaning they report. APC is antigen presenting cells. So they take a fragment of this microbe that entered your body and they lift it up. They present it. They are antigen presenting cells, and they call other cells to come and destroy. Remember, we talked last week about what an antigen is when we were doing the red blood cells. We said that on the red blood cell, there is a combination and a variety of sugars and lipids on the surface. These are known as the antigen. The antigen. So we have self antigens, that's who we are, and we have non-self antigens. So my self antigens will be tolerated by my immune system. But if I give you my self antigens, your immune system is going to destroy my antigens. So antigens are recognized by my system. You have your own antigens recognized by your own system. Who did we say are the only two ever to have the same glycocalyx, the same antigens? Is it the mom and her baby? We talked about that. The mom and her baby. What is it? I'm sorry? Who are the only two that have the same antigens? If they give each other anything, a kidney, blood, it will not be destroyed. AB, yeah, I'm not talking about I'm not talking about the cross matching. I'm talking, so two people who are AB can give each other kidney. So if you have AB, no, that's different. I'm talking about everything on the surface. So you're talking about AB, that's on the surface of the red blood cell. We're saying every cell has on the surface a mixture, a combination number of sugars, proteins, and lipids, glycoproteins. And these are known as we said it last week, glycocalyx. So remember last week we said the glycocalyx? So the glycocalyx is on the surface. And we said everybody has different glycocalyx except two. Those two, I'm sorry? I'm talking about all the combination of material at the surface of all the cells. So an antigen is a type of a glycocalyx. So the antigen, so the AB, what is that? AB, the B, the A, what is that on the surface of the red blood cell? That's an example of a sugar. That's just sugar. Remember we said last week is the fucose and the galactose and the alpha acetamino galactose. These are the sugars that make your blood type A, blood type B, blood type C. Just sugars. A, B, and C is just sugars. But you don't only have sugars at the surface of your cells. That's on the red blood cell, you only have sugar. But in the rest of the cells, you have sugar and you have protein. they are hybrid, a mixture. Sugar and protein known as glycoprotein. Sugar and lipid on a surface known as glycolipid. So we said glycolipid and glycoprotein together, they have one thing that is known as the glycocalyx. That's the glycocalyx. You know, you have your social security, you have your passport. These are known as legal documents. These are the legal documents. So what you're saying with the blood, that's just one thing, social security. That's just sugar. I'm talking about all the documents on the surface of the cell. These are known as the glycocalyx. We said all the people have different glycocalyx. No two people will ever have glycocalyx the same, except two. We said, is it the mother and her baby? No. No, the mother and her baby don't have the same glycocalyx. I mentioned it last week. Yes. Yeah, I mentioned twins, and I said it wasn't just any twins. I said identical twins. These are the only two who can give each other the same, the liver, they give each other blood because they have the same identical glycocalyx. Identical twins. Okay. These are agranulocytes, and you see, one of you showed me this the other day. That's a lymphocyte. It has a huge nucleus and a halo. So that's going to be on the practical. That model was there. So if you weren't here in lab 1, you got to go examine the models and consult your classmates and group members to let you know from their notes what is, even though it's all on the slides and the book, but you still need to be able to identify it on the model, because that's what we're going to talk about we're going to ask about in lab practical. So this big, huge nucleus with the cytoplasm around it, that's like halo. What is this? That's the lymphocyte. Who has a kidney-shaped nucleus? That's the monocyte. There are no granules. Do you see granules here? Never granules. Very good. Now, leukopoiesis, that is the production of the white blood cells. So in order to make white blood cells, poiesis is the making. Erythropoiesis is making of red blood cells. Leukopoiesis is the making of white blood cells. So hematopoietic stem cells, these are the progenitor cells that have potential to differentiate into different types of cells, into distinct types of colony forming units, CFUs. The colony forming units then go on to produce different cell lines. You have the myeloblast, the monoblast, and the lymphoblast. The myeloblast will give you the myeloid lineage, and these are the neutrophils, the eosinophils, and the basophils. But the monoblast, they form the monocytes. The monoblast form the monocytes. Then lastly, these lymphoblasts. The lymphoblasts, they form all forms of the lymphocytes. So T lymphocytes complete their development in the thymus. That point is very important. This point is really, really important. That is, B lymphocytes are made in the bone marrow and they mature in the bone marrow. B lymphocytes are made in the bone marrow and they mature in the bone marrow. While T lymphocytes are made in the bone marrow, but they mature where? In the thymus. So the red bone marrow, from the name, red bone marrow. The red bone marrow stores and releases the granules and these monocytes. This is where the blood cells are made. So circulating white blood cells do not stay in blood for very long. So granulocytes leave in 4 to 8 hours, and they live another 4 to 5 days. Monocytes leave in 20 hours. So this is just to show you the significance of how long do they stay in the blood and before they are removed. Lymphocytes provide long-term immunity for decades, being continuously recycled from blood to tissue fluid to lymph and back to the blood. So remember, granulocytes, these are the white blood cells that are neutrophils, and the basophils and the eosinophils live in 4 to 8 hours, the bone marrow, and they live for only 4 to 5 days because they're just there for the infection. The monocytes, they live in 20 hours and they transform. You see the Pokemons, they transform from monocytes into macrophage and live for a few years. And lymphocytes provide long-term immunity for decades. There we go. This chart is very important because it shows you have hematopoietic stem cells. These hematopoietic stem cells, they have colony forming units. These are CFUs. These colony forming units, meaning they must. So why would this? So you know the stem cell could become anything. You know you can have dough and you add egg and butter to it. That could become bread. That could become cake. That could become pancake. It can become anything. Same thing here. These hematopoietic cells, they are the original form, but they can become eosinophil, they can become basophil, they could become neutrophil, they could become monocyte, they could become lymphocyte based. What makes them go in that direction? What makes the stem cell go and become eosinophil and not basophil? What makes it go to become basophil but not neutrophil? It is the cytokine. So when you are infected by bacteria, bacteria are going to be received by the neutrophils, and the neutrophils and the lymphocytes, they're going to be taking fragments. Remember the antigen presenting cells? And then your immune cells are going to they're going to call for backup they don't call by phone, they call by cytokine. They secrete cytokine. Then your bone marrow is saying, oh, I received the cytokine for neutrophil. That means we are currently undergoing bacterial infection. Let me make colony forming units for neutrophils. If you get infected by a parasite, then there would be antigen presenting cells that would show that there is parasitic infection. Let me now secrete eosinophil. If you're attacked by a virus, same thing. So it is the cytokine. The same way your mood. Am I going to make butter? Am I going to make bread or cake or pancake or cookies? What makes them take the stem cell to what it is the cytokine. So that's why, and when you take pharmacology, when you take the medications, you see that sometimes we have medications that stop the cytokines. So somebody with asthma, they have hypersensitivity to pet dander or something that is really not harmless, something like pollen. So once it goes in, your body is gonna think that it is some form of a foreign invader. So it's gonna do antigen presenting cell and secrete cytokine. So now you're gonna take these the Montelukast, the singulaire. That's what it does. The singulaire, the Montelukast is gonna block the site where the cytokine bind. So the cytokine for inflammation is not gonna bind because Montelukast already shut it down. So you're not gonna have inflammation. So the Montelukast, the singulaire, is gonna relax you because even though your body is saying there is pollen is really dangerous bacteria, but the message is not getting through because Montelukast is like a lock and a key. The Montelukast is bind to the receptor, is not allowing the cytokines to bind. So we have the cytokines are the messages. So you had your hand up, Chelsea. Yeah.
I just wanted to. So is that why? Well, now it's more popular, but women like to stem cells from the.
So we have different types of stem cells. These are stem cells for the blood. There are stem cells in the brain. So now you see that, now they want to treat brain cancer, they want to treat stroke by planting neuron stem cells because they have the potential to grow, even though the brain is non-regenerative tissue. But at some point it did grow when you were a baby. Your brain is not as big as it is when it was a baby. So my brain is bigger now compared to 10 or 15 years ago. It was already big, now it's even bigger. But anyways, thank God. But anyways, the they have the potential to grow, the potential to differentiate and enter the cell division cycle. Now, I don't understand. You mean why do the women? So what do you mean? Why do the women like keep their stem cells?
Yeah, you know,
The ovary. Mhm.
yeah, the umbilical cord,
For what? From the umbilical cord? I never heard of that. Interesting.
I'm talking about the right thing.
Yeah, I never heard of it though. How come I never heard of that? So when did this happen? Last year? Mm,
No more, like, more people are knowing about it now.
mm.
Yeah, they do that.
Yeah, that sounds interesting. I never heard of it. I gotta look into that. That's very interesting. I've heard of, you know, some women donating their um eggs to like some other women to, or having their zygote grow in the body of another woman, or surrogate mothers. And then there is the, freezing up the eggs and for some time then fertilizing them. What is that called now? So so what is that? So a mom would donate or keep her in vitro. Mhm. And they get to have the so, I get it. I get it. Oh wow. Yeah, this is interesting. Yeah. Yeah. So this is the stem cell, and then it goes through the path. But what is the committed step? The committed step is from here to here. When you become a CFU, there's no going back. If you're on a CFU, eosinophil, is there an arrow pointing from here downward? So you cannot go from eosinophil to basophil. You cannot go from basophil to neutrophil. You cannot go from neutrophil to monocyte, and you cannot go from monocyte to lymphocyte. You cannot go vertically. You must go horizontally. When you become a eosinophil, you become a myeloblast, and then you end up as a eosinophil. You see, but you cannot go anywhere else. If you get the cytokine for eosinophil, you're gonna go all the way till you become a eosinophil, a basophil, or a neutrophil. Okay. Now diseases. There is leukopenia. Penia is drop. Cytosis is meaning a lot. So leukopenia is when there is a drop in the white blood cell count below 5,000 white blood cells. The causes are radiation, poisons, and infectious disease. And the effects are elevated risk of infection. So if there is a leukopenia, that is usually happening when there is cancer chemotherapy. In cancer chemotherapy, and during radiation or infectious disease. So in infectious disease, you're consuming. It's like in war. In war, many soldiers are dying. So leukopenia, there is a drop in white blood cell when you have infection. So they get consumed a lot. So you need to make up for them. Or in cancer, this radiation is destroying all the cells, including the white blood cells. So what are the detrimental effects for leukopenia? Yes, the risk of now leukocytosis is when you have high white blood cell count. Leukopenia is when there is less than 5,000 white blood cells. Leukocytosis is when there is high white blood cell count, 10,000. Okay, what are the causes? These are infection. So infection is going to stimulate recruitment of a lot of white blood cells. That's going to cause leukocytosis. Allergy and disease. So leukocytosis also causes hypersensitivity. You have too many of these white blood cells, or disease. Okay, differential white blood cell count. Differential white blood cell count. So the differential white blood cell count identifies what percentage of the total white blood cell count consists of each type of a leukocyte. The differential white blood cell count identifies what percentage of the total white blood cell count consists of each type of leukocyte. Now, leukemia. What is leukemia? Leukemia is the cancer of hematopoietic tissue, usually producing very high numbers of circulating leukocytes. So the effects are there are normal cell the normal cell percentages are disrupted. There's going to be impaired clotting, and there's a lot of opportunistic infections. Even though you have so many white blood cells, you may have the illusion that, hey, I have so many defending cells, but actually no, they are damaged and defected. That increases the infection, the chance for infection. We have different lineages. We have the myeloid lineage and the lymphoid lineage. So in the myeloid lineage, you have uncontrolled granulocyte production. You have too many neutrophils. You have too many basophils. You have too many eosinophils. Lymphoid leukemia, now that is when you have too many lymphocyte or monocyte production. Acute leukemia appears suddenly and progress rapidly, and then there is death within a month. But chronic leukemia is undetected for a month, but the survival time is about 3 years. This is normal and leukemic blood. You see an example of the normal. That's normal blood, and that's leukemic blood. We do complete blood cell count, and that is the profile of data on multiple blood values. We look for the hematocrit, the hemoglobin concentration. We look for the total count of the red blood cells, the reticulocytes, the white blood cells, and the platelets, and the differential white blood cell count. We look for the red blood cell size and the shape, and to see if there's sickle cell anemia, and we look at the hemoglobin concentration per red blood cells. Now we're going to look at the platelets. We know that the platelets are known as band-aids. Yeah. So hemostasis. Hemostasis is the cessation of bleeding, and that involves the platelets. So from the name, hemo is blood. Stasis is stopping. Hemostasis is the cessation of bleeding, and it involves the platelets. Platelets are small fragments of megakaryocytes. They are small fragments of megakaryocytes found in the bone marrow. They are found in the bone marrow. So the normal platelet count is from 130,000 to 400,000 platelets. And the deficiency is known as thrombocytopenia. Remember, hemostasis is the cessation of bleeding, to stop the bleeding completely. Hemo, bleeding, stasis, stopping. So platelets are small fragments of megakaryocytes that are found in the bone marrow. So the normal platelet count is from 130,000 to 400,000 platelets. The deficiency is called thrombocytopenia. So thrombocytopenia is when there is a drop in the platelet count. So the platelet structure, 2 to 4 micrometers in size. There are no nucleus. They don't have a nucleus. They are fragments of the, we said last week, platelets are not cells. Platelets are not cells. Platelets are fragments of bone marrow. Excellent. Good job. They contain granules filled with platelet secretions, and they open the canalicular system, so the internal system of the channels that open onto the platelet surface. So when activated, they are capable of amoeboid movement. Platelet functions are diverse. Platelet functions are diverse. So they secrete vasoconstrictors that stimulate vessel constriction, and they help reduce the blood loss. So the platelet functions are diverse, and they secrete. So you know now they're all about stopping blood loss. So are they going to be vasodilating or vasoconstricting? Excellent. So it makes perfect sense that platelets are going to be, you know, they have granules too. So they have granules in which they have these vasoconstricting thromboxanes, these vasoconstricting substances to stop the secretion of blood vessels. So they secrete vasoconstrictors that stimulate vessel constriction, and they help reduce the blood loss. They help reduce blood loss. They stick together to form platelet plugs to seal the small breaks, and they secrete procoagulants. They secrete procoagulants or clotting factors to promote clotting. They initiate the formation of the clot dissolving enzyme, and they chemically attract the neutrophils and the monocytes to the sites of the inflammation. They phagocytize and destroy the bacteria, and they secrete growth factors that stimulate mitosis to repair angiogenesis, to repair the blood vessel formation. These are the platelets, and you know they initiate formation of clot dissolving enzymes. So after they save us from losing blood, they're gonna have to stop clumping together. So they secrete procoagulants or clotting factors to promote clotting. Then after the injury has been sealed and we are healing, then they initiate the formation of the clot dissolving enzyme. And then this lysine enzyme is going to degrade all this accumulation of the red blood cells. So they phagocytize and destroy the bacteria, and they secrete growth factors that stimulate mitosis to repair blood vessels. Okay. So these are the platelets, you see, and you see these are the megakaryocytes. That's where the platelets come from. This is very important for you to know that megakaryocytes are the ones who give birth to platelets. You see this huge mega, so big. This megakaryocyte is secreting what? secreting the platelets. So platelets came from this huge mega karyocyte. Thrombopoiesis. Thrombopoiesis means the production of platelets. So thrombopoietin triggers the stem cells to become megakaryoblast. They so the thrombopoietin triggers stem cells to become megakaryoblast. So the megakaryoblast repeatedly replicate the DNA without dividing. So these are the megakaryoblast. And platelets circulate freely for 5 to 6 days. Hemostasis. Hemostasis involves three mechanisms. It's very important to know these three mechanisms. Vascular spasm, platelet plug formation, and blood clotting. Vascular spasm. So there's no hemostasis. We're never going to stop bleeding unless we have vascular spasm. We need to have vascular spasm. And we need to make platelet plug. We need to make a platelet, we need to form a platelet plug formation. And blood clotting. We need to clot the blood, and so we need the three. We need to make vascular spasm, then we need to recruit the band-aids, the platelet plugs, and make platelet plug formation. And finally, we need to perform blood clotting, known as the coagulation. Those are the three most important stages. So let's begin with the first one, the vascular spasm. The vascular spasm is when we squeeze and there's a prompt vasoconstriction of the broken vessel to prevent it from leaking the blood. The most immediate protection against blood loss, because we don't want hypovolemia. We don't want to lose blood. It provides time for other clotting pathways. The causes are some nociceptors directly trigger vasoconstriction and is a protective prophylactic response to prevent prevent the loss of blood. And platelets release serotonin. Serotonin is a vasoconstrictor. So you see that's the first stage, vascular spasm, vasospasm, and platelet plug formation. That is the platelet plug. That's platelet plug formation. And coagulation is when you have a blood clot that forms to prevent the loss of the blood. So you see vascular spasm, platelet plug formation, and the thrombus or the coagulation or the blood clot formation. Now let's look at platelet plug formation. In platelet plug formation, the endothelium of the intact vessels is very smooth and coated with prostacyclin. Prostacyclin is very important. That's a platelet repellent. So when platelets are circulating by, hey, do you need me to stick to you? Do you need Band-Aid? Are you bleeding? Who's going to repel them and say, get away from here. Do not stick to this surface. We're not bleeding. We don't need Band-Aid. It's prostacyclin. And they call it prostacyclin because it was first found in the prostate. Prostacyclin. So the broken vessels expose the collagen. So the platelet pseudopods, remember the pseudopods, the appendages, they need to crawl and walk with to the site of the damage. So the platelet pseudopods stick to the damaged vessel and the other platelets. So the pseudopods will contract and they draw together, making a platelet plug. So the platelets is like a positive feedback. So one platelet stick and with its pseudopods is going to bring in another platelet, platelet number 2. Platelet number 2 and 1 with their pseudopods going to bring in platelet number 3. So they're going to make a plug. 1, 2, 3, 4, 5. So it's like a positive feedback. Then they make one big platelet plug. So they help each other. Then the platelets will finally undergo degranulation. Degranulation is the exocytosis of cytoplasmic granules and factors that promote hemostasis. So now they're gonna exocytose substance from their granules that is gonna ensure that the blood is gonna stop. We're gonna make the blood hypercoagulable and thick, and because if it was thin, it's gonna leak out. So now serotonin is gonna be secreted, is a vasoconstrictor. Adenine diphosphate, ADP, attracts and degranulates more platelets. You see, it's a positive feedback. The more platelets, the better. The more we need, the more platelets as we can. So to prevent blood loss, blood is very precious. We don't want hypovolemia. Then thromboxane A2, that's very important. Thromboxane A2 is eicosanoid. That's an example of a prostaglandin that promotes platelet aggregation, degranulation, and vasoconstriction. You see, all of this is in the same direction of hypercoagulability and band-aid formation, the platelet plug formation, and prevention of the loss of the blood. So you see positive feedback cycle. So if you're asked ever, an example of positive feedback cycle is is active until there's a break in until the break in the vessel is sealed. Coagulation is the clotting. Coagulation is the last and the most effective defense. Last and most effective defense against bleeding. So there's a conversion of the plasma protein fibrinogen into insoluble fibrin. And these are threads to form the framework of clotting. So very important to know that the coagulation or clotting formation, that is going to be the first stage or the middle or the last stage. That's the last stage. What was the first stage? The vascular spasm. Excellent. What was the middle stage? Platelet plug formation. What was the last stage? Coagulation. Okay, so there's a reaction cascade where we activate one factor and it will activate the next. So the last and the most effective defense against bleeding. So there's a conversion of plasma protein fibrinogen into insoluble fibrin threads. So we convert plasma protein fibrinogen. Nogen means inactive. So we cut nogen, it becomes fibrin, then it becomes activated. Fibrin threads to form a framework of clot. So the procoagulants, these are the ones that promote the fibrin threads. These are present in the plasma. So remember we said plasma, when you remove fibrin from it, what does it become? So plasma has all the proteins, the electrolytes, the neurotransmitters, the hormones, the sugars, and this clotting factor, the fibrinogen. If you remove the fibrinogen, you keep everything else. Is it still plasma? Serum. Excellent. Becomes serum. Very good. So there's usually the procoagulants are formed in the liver. That's why people who have alcoholic liver disease or have cirrhotic liver disease, their problem is they can bleed to death because the procoagulable proteins are not working, because they are produced from the liver, but the liver is not able to produce them. Reaction cascade. The reaction cascade activate one factor and it will activate the next. Reaction cascade activates one factor and it will activate the next. There are two reaction pathways, an extrinsic and an intrinsic mechanism. Extrinsic mechanism, you would have the clotting factors from sources outside the blood. That's why we call them extrinsic factors. They are released by the damaged vessel and the perivascular tissue. They are initiated by tissue thromboplastin, factor 3. While the intrinsic mechanism is usually only clotting factors that are found in the blood itself. They are initiated by platelets releasing factor 12, and both pathways require calcium. That's very important. Intrinsic and extrinsic mechanisms require calcium. So we use tissue thromboplastin in extrinsic or intrinsic mechanism. In the extrinsic. So you see that's the extrinsic mechanism and that's the intrinsic mechanism. So you see this is the reaction cascade, and hemostasis culminates with the completion of coagulation. So after activation of factor 10, the remaining events are known as the common pathway. They are identical in the extrinsic and intrinsic mechanisms. So that is after factor 10. When you see, that's known as the common pathway. What does X stand for? 10. So that is factor 10. So in factor 10, activation of factor 10 leads to the production of prothrombin activator, an enzyme that converts, remember, pro or nugin means inactive. It's going to convert prothrombin into thrombin. Fibrinogen, when you cut the nugin and it becomes fibrin, is working, is activated now, is on, used to be off. Prothrombin, prothrombin. If you cut pro, is now thrombin, what is that? Is now activated. So thrombin converts fibrinogen into fibrin monomers, which covalently bind to form a fibrin polymer. Factor 13 cross links fibrin polymer strands, and there's a positive feedback. So it takes place through, one thrombin also forms prothrombin activator. So the same way we have platelets recruiting more platelets, we have thrombin recruiting more thrombin and initiating this activation of more hypercoagulability. Completion of the coagulation. So there is clot retraction because now we are done. We stop the bleeding. The platelet pseudopods adhere to fibrin strands and they contract. So the clot becomes more compact within 30 minutes. Overall, the efficiency in coagulation can be measured with the bleeding time after 1 millimeter deep incision. So what is the fate of the blood clots? So after the clot has formed, tissue repair is going to begin. So now we want to repair this tissue that we already saved it from losing a lot of blood. So you have the platelet-derived growth factor, PDGF, platelet-derived growth factor. That's the cytokine that is going to stimulate the platelet-derived growth factor is going to stimulate the endothelial activity. So it's secreted by the platelets and endothelial cells, and it stimulates mitotic stimulates for fibroblasts and smooth muscles to multiply and repair the damaged tissue. That is known as angiogenesis. Angiogenesis is when we make new blood vessels. Angiogenesis is when genesis is the making. Angio is the blood. So that's one of the videos you will summarize, the video on angiogenesis. So you'll see me explaining to you what is angiogenesis, or the birth of these new cells, new blood cells from other blood cells. Fibrinolysis. Lysis is the breakdown. So that's the dissolution of a blood clot, and it occurs after the tissue repair is complete. Occurs after tissue repair is complete. And factor 12 catalyzes the formation of kallikrein, and kallikrein converts plasminogen. You see, plasminogen is going to be converted into plasmin. And plasmin is a fibrin dissolving enzyme. That's going to break up the clot because now we have already healed. We don't need any clot. Clot is only important to prevent the blood loss. But now we already had the Band-Aid, had the platelet, we formed the clot, we stopped the loss. We're no longer in fear of hypovolemia. So now we need to initiate the path for healing. So kallikrein comes in and prevents plasminogen into plasmin. And plasmin is like a knife. It's going to cut this meshwork, this network of fibrin with the platelets. Okay, so you see prekallikrein factor 12 is going to convert pre or pro or negin, meaning inactive. It's going to convert prekallikrein into kallikrein, and kallikrein is going to convert plasminogen into just plasmin, and plasmin is going to dissolute, causing clot dissolution, breaking the fibrin polymer into degradation products. So we need to prevent inappropriate clotting. We need to prevent inappropriate clotting by, we need to control the coagulation. So we need platelet repulsion. So platelets do not adhere to the prostacyclin-coated endothelium. We said that because prostacyclin is going to repel all these platelets that are recruited to the site of the blood vessel. And dilution is important because small amounts of the thrombin form spontaneously in the plasma. And we need our anticoagulants, and these are the heparin and the antithrombin secreted from the liver to stop any potential hypercoagulability in the blood. Okay, lastly, these are the clotting disorders. This is just to show you what may go wrong. Hemophilia is a family disease that is characterized by the inability to clot. So hemophilia patients will suffer from excessive blood loss or excessive blood thinning. That results in a failure of the blood to clot. And unwanted clotting is known as thrombosis. So there is severe thrombus formation leading to an embolus. This is what we were worried about with pregnant mothers that have a clot that will dislodge and travel upward from the bottom of the foot and with follow the blood pressure and enter the heart, and then they can get pumped from the heart into the pulmonary artery. So how do we manage blood clotting? By preventing the clots. And you know, vitamin K is vitamin K is important for clotting. So we want antagonists of vitamin K, such as coumarin and warfarin. So warfarin is gonna, because remember, vitamin K is required to clot. So you know by the name K clot. You need vitamin K to make blood clot. So if you want to stop the blood clotting, you use antagonists of vitamin K, and that would be the coumarin and the warfarin. And then we need to dissolve any pre-existing. So the vitamin K antagonists, the coumarins and the warfarins are there to stop any potential coagulation. But remember, that's for the future. What about the past? We already have too much coagulation. And for that, we're going to need streptokinase. Streptokinase is an enzyme that is made by the Streptococcus bacteria. That's why they name it after it, Streptococcus, used to dissolve the clots in the coronary vessels. TPA is tissue plasminogen activator. That converts plasminogen in the clot so TPA is very similar to our good friend plasmin. It converts, is very similar to kallikrein. It converts plasminogen into plasmin. But we synthesize TPA is going to convert. That's like a modulator. It mimics. Who does it mimic? Who does TPA mimic? It mimics kallikrein because it converts plasminogen from off into plasmin on. But we don't have kallikrein in the pharmacy. We have TPA, tissue plasminogen activator. From the name, it's very interesting. TPA, tissue plasminogen activator. Plasminogen is inactive, is going to activate plasminogen into plasmin, and that's going to cut up the knife with a scissor. It's going to cut up the clot and thin up the blood. And Himentin is an anticoagulant originating from a leech that is found in the Amazon. Okay, so according to the syllabus, we